be ready to share the prayer song. Thank you very much. I'll come back. Yeah.
Yes. Good evening, everyone. Wholeheartedly, I would like to welcome all FOGSI office bearers, all COSOG office bearers, today's chief guests, today's guest of honors, all senior faculties. Am I audible, madam? Yeah. Yes. Am
Yeah,
I
you are
audible,
very
madam?
clear,
Yes.
Manohar. Very
Please,
clear.
some
Yeah.
disturbance. Sorry, madam. And all past office bearers and today's moderator, chairperson, speakers, panelists, and all my dear members of FOGSI and COSOGA and my dear colleagues. Today we are here to have a nice CME on the 7H CME, which was planned by Madam Sheila Mane, Madam Chairperson ICOG, in collaboration with our COSOGA. We have eminent speakers and chairpersons, panelists for discussion, and the most experienced obstetricians and our patrons for backing up our knowledge. Now, without wasting much time, I request Arun to play invocation song, and we can continue the things. Arun, can you play the? Yeah. Yes, ma'am. Thank you, Arun. Without wasting much time, I request our beloved President, Dr. Rajesh Palladi, Madam, to give
My pranams to everybody.
gathering. Yes,
Can you hear me?
to,
Yes.
yes, Madam, you are audible.
Okay. My pranams to all the respected members, dignitaries, faculties, and all the delegates who have logged into this wonderful program of collaboration to spreading the academics with the ICOG and the CASOGA. We know that ICOG, at the helm of the affairs of teaching, has always been leading to give in the valuable inputs and the value-based education and a very robust system of evidence-based practice. And I'm very, very proud, happy, and glad that our respected ICOG chairperson, Dr. Sheila Mane, ma'am, I think she has 24/7 activities for ICOG, always dedicating her time to see what more and what best can be done for ICOG. And we were very happy and glad that Dr. Sheila Mane, ma'am, associated and gave us an opportunity with Kasoga to spread in and take over this valuable project ahead. Um, many things are in row, and I think 1 year tenure would not be enough for Sheila Mane madam to complete all that she has in her plate to serve. And we have a very efficient team along with Dr. Pratik Dambe and all the respected members of the ICOG and Kasoga. We have Dr. Kanchan Sharma and many other important dignitaries I'm unable to see on the screen because I'm holding my phone. It's not the laptop. So my regards and thanks for having me on this platform. And thank you, Dr. Sheila Mane ma'am and dear Shobha Gudi ma'am. What can I say about her um, dedication to whatever effort and whatever task she has to deal with? She puts in her days and nights and all the minutes of fine tuning and thinking into bringing in the best for whatever is offered to her. Thank you, everybody, and wishing this program a great success.
Thank you so much, Madam. Thank you for
Thank you.
your very nice presidential address. Now, I would like to request our beloved Secretary General Dr. Shobha Godi Madam to address the gathering, as well as also introduce our today's chief guests, our President FOGSI, as well as Sheila Madam. Mic to you, Madam.
Yeah. Thank you very much, Manohar. Thanks a lot.
Yes,
Very warm welcome and Good evening to all dignitaries of FOGSI who have joined. I can see the ICOG chair, the ICOG secretary. I'm really keen that Dr. Bhaskar Pal would get few minutes, just like Rajeshri did, come and address as president. I'm still trying for that, but he said that Tuesday is a especially busy day for him because so many people come to meet him on Tuesday. I'm hoping that Soma would get across to him, and because we have already informed him repeatedly, let me hope he puts in an appearance. I'm really grateful to Dr. Sheila Mane for giving us the opportunity to take forward her vision in this way. Very nice to see the Vice President Foxy from the South Zone, Vidya here. Vidya Tobi. Welcome, Vidya. Thank you for being here. And so many chairpersons, Kanchan Sharma, and I could see so many others. We have our own Kasoga faculty also here. Quite a few. Thanks everybody for joining. I can see past President BSOG, Dr. Shubha Ramarao, and quite others. Warm welcome to all of you. Now, the thing is, it is my duty to bring in some introduction here. Can you please share the slides? We'll keep the President Foxy mentioned here so that whenever he joins directly, we can take his message. So, with due respect to Foxy and Foxy readership, let me just say that Dr. Bhaskar Pal has been an amazing academician and a real leader for bringing in a lot of new information, new vibrancy to Foxians through Reach CMEs. We have all witnessed the success of Reach and so many other conferences as well as publications. And every event has been a real major success since he has taken over. Of course, he is from Kolkata, Apollo Multi-Speciality Hospital, and he has chaired the endoscopy committee of FOGSI, CEPOG as well, and is part of the AICC RCOG in 21-23 as chair. President IAGE also. His time in IG was really very happening, and he has been the FOGSI representative to CEPOG. Welcome, Bhaskar. I do hope you find time today. You find some few moments for Kasoga today. Thank you for at least agreeing to come in principle. Let me hope that you show up. Thank you very much. Next, we have the dynamic leader, a very dear friend, actually mentor to many of us, the chairperson of ICOG, Dr. Sheila Mane. It's very hard to put everything in
Shobha,
perspective.
Shobha,
A
Shobha,
lot of, yeah, 1 minute, just a minute.
Shobha, we are all together. Enough. We'll just proceed with academic.
Okay. So, many positions she is holding right now, but of course, she is leading ICOG, and one can see the success of every webinar which is being conducted under her, and is working very hard for the upcoming conference. Definitely, her work in PPH is known to the world today, not just to our country. Welcome, Sheila, and Arun, please stop sharing the slides for a time so that Madam can give her address. Thank you, Arun. Yeah.
Mhm. Thank you. Thank you, Dr. Rajeshri and Dr. Shobha for accepting the ICOG invitation to conduct this 7H CME. And I think aptly, the Kasoka has selected topics like high BMI, HIV, AIDS, as well as the anemia. I think which are very relevant. All of us, we know about it. For HIV also, now the NACO has so many guidelines and the new drugs. So it's very important to know about that also. And I'm sure that all the speakers will definitely be doing a justice to their topic. And anemia panel, none other than I think Dr. Billad is going to conduct and moderate that. So that also, and very happy to see the participation of so many societies. I think Kasoga coming together on so platform is really nice to see. And I must say that Kasoga is on right track now. Everybody is taking interest in academics. Every society is going ahead.
Yeah.
Everybody is participating. and that is very fulfilling and it gives a lot of happiness. So I wish all the
Sheila,
best
everybody
for
was
this.
keen to
See,
know
other four,
what is 7H? What is 7H?
yeah,
Yeah.
that's what I'm coming to that. So 3H, you already know, high BMI, HIV, and HB is anemia. The other four are hemorrhage, hypertension, hyperglycemia, and hormones. So by rotation, the societies select whichever they want to take the three topics. Now we have a few more societies also in Kasoga, no Shobha? So one more round of CME will happen again with other. So again we can have some other. So it's nice to cover. I think these seven topics are very important. So we thought of having these 7H CMEs, and the modules are already prepared. But those who want to speak can definitely make changes. But I thought that by streamlining like this, we are doing it all over the country with all our 294 societies. So state-wise, I'm doing it, and it's giving a very good response. So we have already finished Bihar, Jharkhand. Then we are doing in MP and Bengal next week. We have done Maharashtra, and we have started now Karnataka, and shortly we will be doing Madhya Pradesh and Chhattisgarh and everywhere almost. So thank you, Shobha, for taking the
Thank you.
lead, and I wish all the best.
Thank you, Sheila. Thanks a lot. I wish more and more people would benefit from these topics being discussed in depth. Of course, there is a splurge of webinars today, but having a focus and deliberations by senior faculty does make a difference. So, over to you, Manohar. If you could just mention the guests of honor, and then I
Yes,
could
madam.
introduce Dr. Pratik. Please mention the guests of
Yes,
honor,
madam.
please.
Yes, madam. Thank you so much, madam, for a nice introduction and giving a nice secretary speech. And madam has introduced the madam. Like we have right now today, we have the guest of honors, Dr. M. G. Hiramant sir, the well-known person, and as well as the Dr. Nagaraj H. sir. So we have the presidential, like we have the guest of honors. I no need to go in detail as everybody knows M.G. Ramat sir. Sir is now chief
Arun can
patron.
briefly flash the CV so that we can pay our
Yes, ma'am.
respects to them, and then we can continue. Yeah.
Ha, ma'am. That will be better, ma'am. So we have, yes, sir, M.G. Ramat sir. Sir is the chief patron right now, and he is the founder, secretary, and past president of Karnataka OBJ Society. Sir was also the former, like he was a past vice president of FOGSI Mumbai, and sir was like started his journey in like KMC KIMS Hubli. He was like he was the director. He was a student, past student, and he was a director. Then he was the like honorary for so many colleges, and he was a ex
Yeah.
principal also.
Yeah. We'll
The
wait
he
for
is
Sir to come, Manohar.
third to come.
You
Yes,
can
madam,
just
definitely,
pay
madam.
respects to Dr.
Spare respect to
Nagaraj, sir.
Nagraj sir also. Yes, madam.
Can you share the next slide, please? Yeah.
Yes, sir.
I really wish Sir
And
was here, but he has
yes, sir.
gone to attend. Yeah.
That meeting one. Yes, madam.
Yes.
Dr. Nagraj sir. Sir is practicing obstetrics since 54 years. He is the patron of Kasaga, the former president of Kasaga, EC member of Kasaga, the charter member of the Kasaga 1986, founder president of Shimoga Society, OBG Society,
Yeah.
organized Kasaga State Conference 2005 as well as 2017 in
Yeah. Thank
Shimoga.
you, Manohar. I
Thank you,
think
madam. Yes,
Nagraj
madam.
sir has really inspired Shimoga OBG Society,
Yes,
its
madam.
members, and
So,
all members of Kasoga to reach greater heights. Thank you, Nagraj sir. Next,
yes, madam.
can I have the pleasure of
Please.
introducing the Secretary
Please,
of
madam. I
ICOG?
request,
Yeah,
madam. Yes,
yeah,
madam. I request you to kindly introduce the
yeah.
secretary
So
of Assembly.
this is a very dense CV, of course,
Yes.
befitting the work of
Yes,
Dr.
not
Pratik
fitting into
Tambe,
this.
the
Yes,
IVF
madam.
consultant and gynae endoscopic surgeon from Mumbai, and director of an International Institute of Excellence in Reproductive Medicine as well, Repro Evolvia. That's a nice name. And Repro Evolvia. Okay. He is having several credentials, of course, very high training for assisted reproduction. He was governing council member. I think those of us who have served ICOG along with him realize how dedicated he has been to the Indian College of Obs and Gynecology. And when he was chairperson for the FOGSI Endocrinology Committee, I think he has touched the society almost every day of the 365 days. I don't know how he managed and how much energy he has, but very befittingly, he also won the Best Committee Chairperson Award. So, over to you, Dr. Pratik, to say a few words on this occasion. Welcome to Kasoga. Please talk,
Thank
sir.
you very much, Dr. Shobha Guri and Dr. Rajeshri Kaladi. Thank you very much for inviting me. It's always a pleasure and a privilege to be with Kasuga. Kasuga, like Amox, is a very small, well-knit organization run by a lot of dedicated and passionate academicians. I think both of our organizations actually have been born, brought up, and grown in a similar fashion. I'm very happy to see so many friends and colleagues. I must place on record my gratitude to Dr. Sheila Mane ma'am for taking up this 7H CME series in such a big way and trying to touch each and every single small society in the Federation. There are many small societies where it's physically impossible for us to travel. They are inaccessible, getting dates is difficult, finding sponsorship is next to impossible. But through this online medium, we are connected to everybody, and we really would love to spread the light of knowledge and modern therapeutics in a proper evidence-based fashion, as Dr. Sheila Mani has taken it upon her in this particular tenure. Hats off to you, ma'am, for your passion and your dedication. And salute to everybody at Kasoga for doing a fantastic job. I look forward to having more and more collaborations with Kasoga. And of course, the annual ICOG is in Bangalore. We look forward to
Yes.
seeing many of you on 22nd and 23rd of August in Bangalore for the annual ICOG conference. Thank you again for inviting me. It's always a pleasure and a privilege to be with Professor Toby, Dr. Shobha Gudi. We have been committee chairpersons together. You've now grown up to be vice presidents. I'm really happy to see your progress, and I hope to see some of you as presidents one day as well.
I
Well,
think
that
Shobha,
is,
Bhaskar
yeah,
is not there. We can just ask Vidya Toby to
of
say a
course,
few
of
words.
course. Yes, yes.
Yes, ma'am.
Vidya Tobi and Dr. Suman Gaddi, one after the other. So, Dr. Suman Gaddi is the president-elect of Kasoga. So, it's befitting. Dr. Vidya?
Vidya, madam?
So welcome all
Yes, ma'am.
Kasogians, Foxians, and ICOGians. So I am really happy about this venture of Dr. Sheila Mane, who is also very dear to me. She is also a mentor for me in various aspects, and I must congratulate Shobha Gudi for taking this forward, and Dr. Rajeshri Palladi and other dignitaries on the dais. All many of the president secretaries of Kasoga have joined, as well as I must say that please propagate that 22nd, 23rd, whatever conference is there in Karnataka of ICOG. Please make sure that from your society many ICOG fellows application go in, and please come for this ICOG conference. ICOG is a platform for the academicians of all the fields, be it a fetal medicine, be it a gynecology, or be it many aspects of things are discussed. And I must say that Dr. Sheila Mane has taken this ICOG at greater heights. Just now we are witnessed the AAB certificate course, and also there are various exams which are conducted by ICOG. There are ICOG certified centers where you can undertake the certificate courses and training courses as well. I must congratulate Dr. Pratik Tambe for taking much interest and in Kasoga as well as various programs. I always appreciate his academics. Thank you very much. Without wasting much time, I'm eager to listen to various speakers of today's Dr. Rajashri Aliwal, who is again a great academician of my place. She will be speaking. So I'm eager to listen to other speakers as well. Thank you, Sheila, for calling me for this platform. Thank you very much. Thank you, Shobha again. Thank you.
Thank you. Thank you. Dr. Suman?
Suman,
Good
madam?
evening. Good evening to all dignitaries. I welcome all the Foxians, Isogians, and Kasogians to this webinar. And I also congratulate Dr. Sheila Mane, Dr. Pratik Tambe, Dr. Shobha Gudi, and Dr. Rajeshwari Paladi for taking this webinar forward. And however, we are very eager to listen to our speakers. Thank you, one and all.
Thank
Yes.
you. And now over to you, Manohar. You can invite
Yes.
the chairpersons and we can start the session. Yeah, invite the
So,
chairpersons, please. Yes.
thank you, Shobha. Good evening, madam. You made my job very easy, madam, by introducing everybody. And without wasting much time, we will start. Shall we start the session, madam? So, first session, we have first session on obesity in women health becoming impact on high BMI on women health. So, Dr. Rajeshri Elwad, madam, and Sanjana Tallur, madam, is
Yeah.
Rajeshri Elwad, madam is talking on this, and chairperson being Umesh Deshmukh as well as Dr. Ashalata Malapur.
Uma Deshmukh, Dr.
Uma
Uma
Deshmukh,
Deshmukh.
sorry, Uma Deshmukh.
And can you introduce the chairperson
Yes,
so
madam.
that they can introduce
Hello.
the speakers? Yeah.
Hello. Yeah,
Hello.
first let me introduce Dr. Ashalata Malapur, madam. Malapur madam is our professor. I am working under her in SN Medical College, Bagalkot. Madam is a very lovely person. She is just mother of our department. I don't know I should tell or not here. Yes, madam. Madam, are you joined, madam? Malappuram. Yes, madam. Madam is HOD of our Department of Obesity Society in SN Medical College. She has 30 years of experience teaching, so more than that. She has rich experience in academic research. She has brought so many publications and grants from to our college as well as to the KLE along with Gowder sir and Bala sir. Hats off to madam. Madam has received so many awards. In the Rajyotsava Award, Academic Excellence Award, and Best Teacher and Best so many awards in our own colleges by our
Thank you,
president.
Pa.
Yes, madam. And madam has multiple publication near to the century. Hopefully, madam will beat now. Thank you, madam. Thank you for joining the session.
Even
Next,
Manohar, even I appreciate Asha's work a
yes,
great
madam.
deal because she is a
Yes,
very
madam.
silent researcher, very silent worker, very modest, and
Yes,
she has
madam.
brought in lot of academics to Bagalkot and
Thank
made
you,
great
madam. Thank you
advances.
so
Yeah,
much.
Asha, I really appreciate you
Sorry,
so much.
Madam is
every
very much
all
energetic, madam.
Yeah,
She is not only in research but in college also. Full most of not only our
yes.
OBG department, full all the departments is
Thank you
behind
so
madam.
much, Manohar. Please
Yes, madam.
invite
thank you.
Dr.
Yes,
Uma
madam.
Deshmukh. Yeah.
Dr. B. Deshmukh, madam. Madam is HOD of OBG BRIMS Bidar. Madam is chairperson for ethical and medical committee. Advisory committee members of PCPNDT Bidar, 96 to 2020. Nodal officer from maternity mortality, Bidar district, 2007. She was 2F for the SBA as a CAC as well as the PPIU CDs. She was 2F for MCSC collaboration with Singapore team. I am a vice president at 2022-23, past president of Bidar Officer Society 2023-24. She was the executive committee member for women of the Dr. Swing 2023-24, 22-23. She was the introducer of Jeevan Raksha ECLS training for most of the medical students. Now, medical students really remembers madam's name. She has received best awards for Doctor's Award, Rajyotsava Awards, so many awards in so many
Thank you, sir.
awards. Feathers are
Thank you,
in
sir.
crown,
Thank you,
madam.
thank
Thank you so
you.
much for joining the
I'm
meeting,
telling on
madam.
your
Thank you.
behalf, he's getting carried away. Can you please
Yes, madam.
introduce the speaker,
Yes,
one of
madam.
the chairperson? Please introduce
Yes,
Rajeshri.
madam.
Asha,
Rajeshwari
ನೀವು
Alvan, madam.
ಮಾಡ್ತೀರಾ? ಅವ್ರು ಮಾಡ್ಲಿ
Ah,
Manohar. Let the
yes,
chairpersons
madam.
take over the session. Yeah.
Yes, madam. Dr. Asha Rajeshri Elwad, madam, is qualified
No, Manohar, let the
MBBS.
chairperson introduce the
Yes,
speaker.
madam. Okay, madam. Thank you, madam.
Okay,
Malapura,
hand it
madam,
over.
or
Hand it over.
Madam. Anybody can
Hello, hi, yes.
just introduce. Yes,
Dr.
madam.
Rajeshri G. Alivar, she's MBBS, MS, and FICOG, PhD, OBG. And she is a professor and unit chief, BLDE. And she presented many papers and in national and the state conferences and publications of national and international journals and a faculty of various regional and state international conferences and awards prize for a presentation in a Kasoga 2009, 2016 and your FOGSI and teacher award, also best teacher award. And she delivered many public awareness talks on PPH in a rural Vijapur and numerous talks on menstrual hygiene management on in schools of Vijapur. And she is also a reviver of journals and editor of BMC, BM in pregnancy and BLD journals. And also she is a society member of former honorary secretary of Vijapur OBG Society and a central committee member of IMA Vijapur and former vice president of IMA Vijapur and former member of adolescent health committee member KSHOG. Welcome, madam.
Thank you, madam. Thank you for introducing madam. Now, shall we start, madam? Rajesh, madam, are you ready with your presentation?
Yes, I am ready, sir.
Yeah, please, madam.
Am I audible, sir?
Yes, yes, Rajeshri, you are
Yes,
audible.
madam. Yes, madam. You are audible, madam.
Please go ahead, Rajeshri.
You are
Please
able
go
to
ahead,
see
madam. You are
the
audible.
PPT?
Yeah, we
Yes.
can see.
Yes,
We
PPT
can
is clear. Everything is fine, madam. You
Please
can go
start.
ahead, madam.
Yeah.
At the outset, I would thank FOGSI and ICOG office bearers for this wonderful opportunity to participate in this program designed by Sheila Mane madam. And a special thanks to Sheila madam, not only for this program, she has been helping us in so many ways, especially she is participating with the government to reduce the mortality of women in our state, and she has given us wonderful tips, and we have implemented those tips in our district, and especially in our hospital. So thank you so much, madam, for that. I would also like to thank
Thank you.
all Kasova office bearers, especially Dr. M.G. Herimat sir, Dr. Nagraj sir, Rajshri Palade madam, Durga Das sir, Suman Gaddi madam, Shobha Gudi madam, especially because she invited me for this wonderful event, and Shobha Bembalki madam as well. I would also like to thank our chairpersons for the lovely introduction, Asha madam and Uma madam. And also I'd like to thank Manohar Tanksale sir for the nice introduction. So, following this, I'd like to say something about the obesity. Obesity is sometimes when we explain this about obesity to the patients that you have to lose weight, then the next thing is they start looking at me because I'm also one of the sufferers of this dreaded disease, and it is not reducing, but it is only going to increase in the future, and it has become to the extent of a epidemic. So how it affects women, how it is going, how it is increasing in our country, and what best way we can control it or treat it is today's topic of discussion. So going on to the sorry obesity rates in India. If you see the map of India, you can see that there is a high prevalence of obesity, especially in the southern states. Other than the southern states, it's in Punjab and Haryana. These are all states which produce a lot of, high, richer states in India. So wherever there is a richness, there it comes with the obesity as well. And if you see the other graphs, we can see here that it is going on to be 15% now. It's rising up to 15%. This is 2019-21. If you would see the latest surveys, then it's going to be higher than the existing ones. State-wise prevalence also is mentioned here in this slide. If you go through this slide, you can see that the highest prevalence of obesity is in states like Tamil Nadu, Delhi, Punjab, and even Karnataka is also not so good in its numbers. And compared to the older numbers which were there, you can see that was done in the National Family Health Survey 2, where the incidences and prevalences were very less. Now they have come up very much. So that means that we are going for not only an increase, it is a fast track of the obesity which is happening. Now, what is the government thinking of that? The government also knows that obesity is increasing, and by 2030, 27.8% of all overweight in the world would be Indians. That means India is going to be contributor in obesity, and thereby India would be Indians would be more prone for diabetes and hypertension and becoming the diabetic capital of the world. That everybody knows. But what are we doing for this? So, as per definition, obesity is defined as excess and abnormal fat accumulation that presents a risk to health. And obesity is a chronic disease that is increasing in prevalence in adults, adolescents, and children, and now considered to be a global epidemic. Prevalence of obesity is higher in females than males across all socioeconomic levels and age groups. In India, obesity is increasing rapidly across all age groups. It has tripled over the past decade. So, obesity actually being termed or coined as a disease is also a newer thing, because in the past it wasn't even called a disease, it was called something, an aberration of the normal. So from there it is now been definitely coined as a disease. So what should we know in obesity is how do you define it, and what is the difference between obesity and overweight, and what are the adverse effects of the high BMI in women of reproductive age group, understanding the pathogenesis of adverse events related to obesity, and optimizing pregnancy outcomes in pregnant women, and how to prevent obesity. So this is the definition regarding the BMI recommendations and classifications of the obesity and overweight. If you see Asian women, they're in Asian women, you call them obese even if they have a BMI of 27.5. But in other women, it's above 30. So even if you are 27.5, you're called obese. But before being obese, 23 to 27 itself is called overweight. So one can be overweight even if they have a BMI of 23 to 27, and this is the target group which has to be controlled before they go in for obesity. Types of obesity. So people can have a apple shape or a apple shape obesity or a pear shape obesity. So pear shape is said to be less dangerous compared to apple shape obesity. That's more of the central obesity. This is more so seen in women, but many of them have a mixed type as well. So if you go for the waist hip ratio, waist diameters at the narrowest part in inches, hip diameter at the widest part in inches is the waist hip ratio. It's normal to be less than 0.85 in women and less than 0.9 in men, and higher ratios associated with metabolic complications. And how does obesity directly affect you? So the visceral fat functions as an active endocrine organ, and it is associated with dysregulation of organs through various pathways: metabolic, vascular, and inflammatory. So this would lead to insulin resistance, vascular dyslipidemia, and inflammatory oxidative stress. So obesity can occur at any time. It could be in the menarche. We do see young girls coming with obesity, or reproductive age group where they may have trouble to conceive, or during the menopause where there is known weight gain. So how obesity affects you? It could be, this is a picture from the government of India. So it could lead to diabetes, increased risk of stroke, fatty liver diseases, kidney diseases, heart diseases, high blood pressure, increased risk of malignancy, sleep apnea, and problems in pregnancy. So this is a list of all the things which could happen due to obesity, including mental health, because many of the women feel that they are depressed because of their looks, or they may be anxious, especially if they are the younger girls going for the marriage, or even the women, even menopausal women also get anxious that they are going to gain weight because their cycles are becoming irregular. Mechanical problems of orthopedic problems like osteoarthritis of the knee, backache, they are all known. Even stress urinary incontinence, that is all higher in obesity patients. Infertility, AUB, cancers like endometrial cancers and breast cancers also are higher in obese women. And metabolic, already I have stated them. So this is another graph which shows the relationship with the BMI and diabetes, which is very high, hypertension also high, cholelithiasis and coronary heart disease also is going to be higher in women with higher BMI. So coming to the impact of infertility, the obesity affects both men and women when it comes to infertility. In men also, it can lead to infertility because it leads to hypogonadism and decreased spermatogenesis, sperm DNA fragmentation, and later on to the male infertility. In women, the end result would be that there is an altered gene expression during the window of implantation, which leads to the defective implantation and maybe abortions. Or it could lead to the abnormal follicular genesis, and therefore they may end up with the abnormal oocyte itself with the mitochondrial damage. So what could happen in pregnancy if the woman does get pregnant? One is she may not get pregnant at all, or if she is pregnant, what are the effects of obesity? It affects all the stages, that is antenatal, intrapartum, and postpartum. In the antenatal stage, she could have abortions or malformation of the fetus. Hypertension and hyperglycemia is also known, and they can go for obstructive sleep apnea, which leads to hypoxia. Intrapartum, again there is a difficulty during delivery, difficulty in fetal monitoring. Many a times you can't look at the FHR. The shoulder dystocias are known, TPH is known, and many times it may be hidden because of the obesity. You can't even palpate her uterus to see whether the tone is adequate or not. Difficulty in labor analgesia, even difficulty in intubation, difficulty even to give spinal anesthesia as well, and increased need for HDU and ICU care. Postnatally, the most important one is the surgical wound site infections. Thromboembolism, lactation may be delayed, postnatal depression, and risk of developing NCDs later in life. Now, I'd like to say certain things more about the surgical site infections. What we are doing in our hospital is that we are using mini-vac drains for all obese patients. So with the mini-vac drain, because of the negative suction, there is less chance of seroma formation, and there is less chance of wound disruption. Because you may have taken great care that it doesn't get infected, but at the end you get a open wound, and that to a big full length open wound like that. So we are using the mini vac drain, which helps in preventing these things, and we are seeing having a good result with that. Going to the fetal effects, though the mother may be obese, it doesn't mean that the baby can be maybe big. She may have growth restriction as well, because it is associated with other diseases like hypertension disorders in pregnancy. Baby may suffer from macrosomia, stillbirth, or preterm. Neonatal effects like birth asphyxia, birth trauma, and failure to thrive, and failure of lactation may be there. And childhood prognosis would be poor cognitive performance may be there, and they are prone for obesity and type 2 diabetes in the future. Going to the fetal origin of adult diseases. So because there is a obesity in the mother, this can affect the fetus also and cause childhood obesity, and also may sometimes dysregulate lung development, and they may develop asthma and atopic dermatitis. Long-term cancer is one of the features which could occur in any person who is obese. Going to the other things like other maternal and childhood problems, already have discussed that mother is susceptible to hypertensive disorders of pregnancy, diabetes, dyslipidemia, and arteriosclerosis, and CAD. And the child could have poor cognitive performance, neurodevelopmental disorders, including cerebral palsy and type 2 diabetes. So how do we deal with this? So if there is a weight loss, before the pregnancy, then all the complications of this obesity could be reduced. So advising women for preconceptional weight loss is very important. So these are the counseling for women seeking the weight loss. In that, you can see that if there is a weight loss, then there is a decrease in all of these things. If there is a weight, she is obese, this is the percentage of things which could increase in the pregnancy. So how do you manage this? How do you manage all of this? So one thing is lifestyle modification is one most important thing which has to be done by the woman, but easier said than done. Even though they go for a lifestyle modification, they do new diet plans. There are 101 apps and people there to guide them. Lifestyle coaches are available. Calorie counters are available. Everything is available, but many of times they can't do it for the longer periods. After 1 month, 2 months, or 6 months, they do it, they lose some weight, and then there is a relapse. So one, that is one thing. Assessment of management and management of mental health status. It is known that if the mental health is not good, then the relapse and the chance to adhere to such therapies is very less. Medical management is one of the hot topics which we'll be discussing now, and bariatric surgery. So this is how you counsel the patient. The moment you say that there is a drug, because it's everybody knows that the drug is available, nobody wants to go for the other modifications like nutritional therapy or physical activity, because it's easy to take a pill rather than to go for a few kilometers walk or to reduce the food intake. However, it is the best way to counsel the patient is to go for the lifestyle modification. Go for first, they should try to change their diets and look into, really look into the diet. Where are they going wrong? Maybe it is not possible for a doctor to sit down and listen to all their dietary habits. So you may need to take a help of a nutritionist who can help them to plan their diet. Physical activity is also the same thing. One has to be dedicated to do physical activity, then only they can lose the weight. Psychological interventions, that is keeping the persons happy and seeing whether they have any um, mm, depression or anything which could change their mood. And then next is the pharmacotherapy, and last is the bariatric surgeries. So in general, weight maintenance is calories in and out should be equal. You want to lose weight, you have to reduce the calories, and if you are eating too much, you will definitely gain. What is the advised physical activity that a woman should have? So under supervision, because we don't want the woman to just jump into the gym and do excessive exercise and then end up with difficult problems, other problems. We have seen many gym goers suffer from cardiovascular events as well. So one has to do slowly be slow with it, and then increase their activity to the extent of every time they want to increase, it's at 5 to 10 minutes extra, not to go just for hours on end suddenly. Dietary approach also should be supervised and flexible, and towards and it should take into consideration the type of diet and her dietary choices. Many people are advising, we do see many people advising things which are not even available in the market, so they are getting them online from different places just to maintain their diets. But one has to be very take into all these things, the local food which is available and local things which they can eat, rather than going for all the time uh, things like I heard some of our women patients quinona and all that, which we don't even get in the local markets, at least in this place. Now, pharmacotherapy, the one which everybody wants you to do immediately, especially young girls, they want the parents come and they just say, give her something, and then we'll reduce her weight and everything will be fine. So everybody is so anxious that they want the weight to come down immediately. So when do you advise? So if the BMI is more than 35 and they have at least one weight related comorbidity, then you can go ahead with this pharmacotherapy. And ideally it should be done by a specialist who is doing and it has to be monitored. It has to be monitored. So one of the contraindications for this would be thyroid cancers, medullary carcinomas, and chronic pancreatitis or any pancreatic disease should be taken into consideration before starting these treatments. So semaglutide or sorry, tirzepatide or liraglutide are the drugs which are available. Old drugs like orlistat, which we have used, which used to lose only around 4 to 5 kgs per year, are not very popular nowadays. So the GLP-1 agonists, that is the semaglutide and the liraglutide, are being used now, and they are available in oral tablets and injectable forms. So how they start first, they will assess the patient whether they are coming into the category to use these drugs, and then later when they start the drug, they will increase the drug on weekly basis to an optimal level. So when they increase the drug, what are they looking for? It causes loss of appetite. Loss of appetite is the most important thing here. So once the appetite is reduced, the food intake is reduced, and the weight loss can be anywhere up to 20 to 30, 40% also. After they get an optimal weight loss, they start decreasing the drug, and slowly after tapering the drug, then after tapering the drug, if you monitor them carefully, then they can wean off the drug, and she should maintain the weight. If the woman relapses back and she, after tapering the drug, she again goes back to her own old eating habits, then this also will not work. So discipline is very, very important when they are using such drugs. So, what does the WHO guideline say? WHO guideline says it emphasizes long-term use of GLP-1 based therapies with intensive behavioral therapy to maximize and sustain weight loss benefits. Because one of the studies, what it stated that after 1 year of using this drug, once patients when the patient stopped the drug, 64% relapsed. They went back to their old weight. So it's like, like it should not be like a Cinderella effect where you just give the drug and then she looks good for some time and then she relapses again. So that's why behavioral therapy is very important, and the woman should also understand that she cannot be on this drug forever. It is for a particular amount of time to reduce her weight, and then it's up to her to maintain her weight at that level. Now, if supposing this is also not working, now before the semaglutide and all came, it was bariatric surgery which was very popular, and now since this pharmacotherapy is working better, that has got a first preference than the bariatric surgery. So if that is not working and they want to go for bariatric surgery, the indications would be for those, it is recommended in those who have severe cardiovascular disease, hypertension, and who have got fatty liver, non-alcoholic fatty liver disease, obstructive sleep apnea, and type 2 diabetes. So in the bariatric surgeries, you have various types of bariatric surgeries, and the most important thing here is when you're advising bariatric surgery, you should understand that the woman is going to have a loss of micronutrients. She's not going to end up with a permanent deficiency of that, and she will go lifelong on supplements. So here the basic thing is you are going to reduce the size of the stomach, reduce the size. Either you put a ball in there, or you cut it, or you put a band, whatever you want to do. The basic thing is to reduce the size of the stomach, and if the woman does not discipline herself, this also, whatever stomach is there, also can expand, and she may lose the benefits of this surgery. So all this has to be explained to them, and of course the contraceptive advice has to be given when they are undergoing this surgery, because she is expected not to conceive for 1 to 2 years.
Hello, madam. Time is up.
Yeah, okay, madam. I'm just done.
Yes.
So prevention, everybody knows about the lifestyle modifications. And to conclude, overweight and obesity are chronic, relapsing, and progressive conditions characterized by excess body fat. And we all know the complications which can occur with obesity and what effects are on pregnancy. and infertility. So we must screen everyone coming in contact for us for medical advice, or otherwise make them aware of this disease and its treatment. So finally, take the first step in faith. You don't have to see the whole staircase. Just take the first step. That was by Martin Luther King Jr. So once again, thank you all for the patient hearing.
That's
Thank you,
very
madam.
nice. Yeah.
Thank you, madam.
Manohar, we can take a few questions.
Yes,
No,
madam.
Uma
Thank you.
and
Yes, madam.
Asha, we can take you can stop sharing. Very nicely told by
Yes,
Rajeshri. Rajeshri,
nicely
stop sharing.
explained,
Yeah,
madam.
thank you.
Anybody has any questions, madam?
Yeah, that's all.
Any
I didn't see
suggestions?
any in the chat box. I'll
Yes,
just see again. I
actually,
just wanted
few
to
things were
know
different.
one
Yes, madam.
thing, Manohar. I just
Yes, madam.
wanted to know semaglutide being a new molecule now. So
Yes,
far,
madam. Semaglutide.
neither BCGI nor the,
GLP.
you know,
Yes, madam.
no,
This is
has
like
not given
GLP-1.
permission to gynecologists for prescription so far. So we are kind of getting patients on board for this drug along with the endocrinologist. Anyone has
Yes,
any experience to share are most welcome from Kasoga. Anyone wants to share
yes,
any
madam.
experience on?
It
Yeah.
has advantage and disadvantage. Madam. I have a little bit experience. It like long term use can cause myopathy, muscle wasting and all. They should be aware. And before giving anesthesia, this should be stopped or like prior to the anesthesia, maybe one week or 1 month.
Yeah,
So these are
especially
things
general
very much
anesthesia.
general
Especially general
anesthesia.
anesthesia. Yeah.
Yes. Otherwise,
So
it's an excellent drug. Madam. Only cost is the most important thing.
mm,
And most people who are
cost
advantaged are
has come
diabetic
down now, Manohar.
come down, madam.
Um,
50% it has
The
come down. It was
problem with
7,000,
us
it has
is
come
that
down
we
to
are not
3,000.
able to directly
Yes,
prescribe. Yeah.
madam.
Mm.
And
The thing you told
one
about
thing is
muscle is
wastage.
because
Apnea,
I feel
sarcopenia, they
correct,
call it.
correct, correct.
Yes, madam.
So there is a bit
So
of muscle
they
wasting, and
wasting. For
even
that now,
as
what they advise
Rajeshri
is,
correctly pointed out that
uh,
no measure will work unless there is lifestyle modification. So there
yes,
has to be a very strong exercise regime, and this
yes, madam.
applies very, very, very importantly to midlife women because they have to bring in the resistance exercises at least 3 times a week and 10,000 steps per day. Now, however
Yes,
difficult it looks, but it is important. Even for us, it is difficult to meet up. When we try to implement it on ourselves, it is difficult. But then, only this will give the best results. Anything,
but
Madam,
Rajeshri?
I have a
Anything?
doubt.
Yeah.
Madam, I
yes,
have a doubt.
please, madam. Please,
Who
madam.
is this? Who takes up this who is a weight management specialist?
Okay.
Because
Yeah, Rajeshri, you have
Is
anything to
Dr.
say?
Rajeshri
actually
has
patient
pointed out
should
that
have been there.
who takes up this,
Who is
specialist
counting
work.
the weight?
Basically,
Not the calorie, the weight.
One
Hello.
question from chat box, madam. Any role of cryolipolysis?
Yeah, Uma, let Rajeshri answer Suman's,
Yes.
then we'll take cryolipolysis.
Yes.
Both.
So, madam, when it comes to nutritionist, okay, one can appoint somebody to take care of your personal. Have a personal dietitian who can do everything for you. But it may not be so much for local. The place where I am working is not so easy for our local people to do that. But there are people in bigger cities who every single meal from morning, breakfast, lunch, dinner, everything they will prepare and give them to, and with the calorie count and everything. So that's one thing. The other extreme of people, not like people in my place at least.
One thing, Rajeshri, I think the concept of obesity clinic is very viable. And Suman's concern is very genuine because, when you have been talking about long-term sustainability of any program, so that is possible only if there is some place to go to, right? And the
Yes,
go-to
Yes.
place can be obesity clinic. Hmm?
but there are a
And
lot of other players in the
yeah.
market. Other than
So
only.
cryolysis, I don't think anybody has experience, Uma. I think we'll have to let that question be. I don't think myocryolysis has come
Madam,
up
some
as a
people
therapy.
have undergone liposuction and all, but they're not very happy with it. Again, they have come
No.
back with the obesity. Some of
Mm.
our colleagues also, because there was a time when it was very popular. and but they are not happy with the
Yeah,
result.
it's only LSM which will keep them on the sustained loss. Otherwise, once we stop the drug, there is a risk of the weight coming back. But with sustained LSM, it will not. It will come up back very, very minimally. That is what is the data is showing. But one thing, what I wanted to tell Rajeshri to everyone, that actually there is a hidden global risk, which for Indians in the entire world, the cardiometabolic risk is very high. The major adverse cardiac events are quite high amongst Indians. And women die more often of cardiac events rather than cancer. So I think these events come down while the women are on therapy because they adhere to LSM better when they are on therapy. So probably all of it makes a difference. And we will reduce the number of cardiac events at least if we strictly follow the protocol and the flow chart for obesity management. With that, I think we'll go on to the next speaker because time is less. Dr. Uma, please introduce Asha Ibralobru. Bring
Dr.
in
Shobha.
Tallur. Yeah.
We can introduce
Dr.
Shobha
Shobha.
Tallur, madam.
Hi.
Yeah. Hi.
Hello.
So I must say that it was a very interesting discussion which took place just now about the obesity. And as you know, one of our stress, I mean, the most important trust we are giving to is about the obesity at all age groups, especially in the adolescent as well. So this was a very relevant topic that we have taken up at this point in time about the obesity, because we know that obesity alone in women is responsible for about 10 cancers. And I think it's very, very well described by Dr. Rajshri Elivan, and I'm glad that you took up this topic to highlight, because I am just going back from a 3-day yoga event which was happening in Kasoga, just to highlight about the way of life one should be taking forward. My agenda is to visit the societies and to encourage and to motivate everybody to get into the academics and also to get into the holistic way of life. So it's time that this topic makes impact about what we intend to do or to create an awareness at all age group. And we know that ASME is one of the important component of our three trilogy of things that we have. Tarunya, we have Master and ASME. And in ASME, and also in Tarunya, we are highlighting on these two important topics. So thank you very much, Dr. Rajshri Elivan, for making this point of highlight, and also taking up such a challenging topic, which now I think we shouldn't be sitting and waiting for what to do next. And it's kind of become a pandemic. And with the altered lifestyle and change in the habits, that is becoming even more prevalent. So maintaining the optimum BMI and maintaining the healthy lifestyle and having a holistic approach for life becomes very mandatory so that we can be charged of our own health. Thank you so much. Thank you, Dr. Shobha, for coordinating, and
Thanks so much,
Rajshri, for
Rajeshri,
taking
for
this topic.
being around.
Yeah.
Thank you so much.
Yeah.
Thank you.
Thank you.
And I request the chairpersons and the next speaker to kind of be, little bit brief so that we can complete this session. Dr. Bellat is waiting to conduct the panel. Please. Yeah. Yes, please introduce. Yeah.
Hello, good evening. Here is Sanjana Patil Tallur. She is Associate Professor in MRMC Kalburgi, North Zone EC member Kasoga. And I am privileged to call her one of my closest friends. I have known her as a sincere and warm-hearted person, and who always strives for excellence.
Yeah.
Welcome, Sanjana, and stage is yours. You can take
Can
over.
I add something about Sanjana? Can I add?
Yes,
With the permission of chairperson.
Ma'am, I will go
Sanjana
with
is
my
very
topic.
efficient. Sanjana is very efficient, and she is also a very cheerful person. I find her very sophisticated in her responses, in social responses. I find her very kind of, what is that, balanced and constrained. I like that quality because some of it I lack, and I aspire for those qualities actually. One thing about Sanjana
I'll
is she's
complete it,
working.
ma'am.
Yeah, she's working very hard for the upcoming Kasoga annual conference, and she is the organizing secretary for that. So, Kasoga, the floor is yours now. Yeah.
Okay, ma'am. Thank you. Ma'am, are you able to see my slides?
Yes, no, it's all clear.
Yeah. Make it full
Visible
screen.
and
Yeah, full screen it is, ma'am.
No, yours is split. Maybe Arun. Yeah.
Arun, it's
split
full
ಆಗಿದೆ
screen.
ನಿಮ್ದು.
Here it is full screen, madam. Yeah.
Okay.
Okay, continue.
Namaskara, good evening, everyone. Out of 7H, the most important H is given to me, I think, HIV, and the most complicated one. So I thank Sheila Mane madam, I thank Shobha Gudi ma'am and Rajeshri Paladi madam for considering me for the second H, that is HIV in pregnancy. So when we were doing our PGs, we were scared and feared of this HIV when a HIV patient used to come to us. But now everything has changed, evolved and evolved. Now we are managing those patients without any fear, I think. All of you agree with this, I suppose. So the HIV in pregnancy has undergone one of the most remarkable transformation in modern obstetrics, from being a fear diagnosis to a fully manageable condition. So the vertical transmission of HIV in India is near to elimination. So according to the Ministry of Health, Family Welfare, NACO and NACP, so if the patient is not on any treatment, the transmission rate accounts for 40%. If she is on ART, then it is less than 5%. If she is on ART with a potential vaccine, it accounts for less than 1% of transmission. So NACP, which was introduced in National AIDS Control Program, which was introduced in 1992. First, when it was introduced, it was there was having a centralized approach, awareness about the disease and the blood safety. Everywhere the banner, everything was put to know, educate the people about the HIV. But coming to the NACP 5 program, which is from 21 to 26, there is a SOCH platform which accounts that the platform helps the patients, the HIV patient, to use the app, that is the HIV app, wherein they get a lot of information, lot of education materials, and they can have a good good life along with those apps. So they can know about their disease, they can track their disease, everything, even the government track their disease also. Then the cluster-based approach. This cluster-based approach is basically the high risk areas are selected and the approach is done, the treatment approach is done in those areas to treat the patient. So these are the two things uh, which are seen in NACP 5, that is the SOCH platform and the clustered based program. So now coming to the challenges ahead, like in India, there are 25 lakh people living with HIV. Among them, 44% are women. So the annual live infection is accounts for 66%. But the thing is that it is reduced. The adult prevalence is reduced from 0.8% to 0.2% nowadays. But that MTCT, mother to child transmission rate, is 11%, which is called as a critical gap. Means we need to reduce that 11% still down. We need to make it down and make it around less than 5%. So usually in an average year, on an average per year, 23,000 to 24,000 pediatric cases are getting infected because of late diagnosis, missed ANC screening, and adherence gap and breastfeeding dilemma. So what this NACP phase 5 says. So this says like we need to reduce the less than 5% in a breastfeeding population, and the case rate of new pediatric HIV due to MTCT less than 5, less than 50 per 1 lakh live births. That means we need to reduce the patient from from a high prevalence to the low prevalence by adopting 95 95 95 rule, that is 95 awareness of their HIV status, which accounts for 95% on HIV treatment, which accounts for 95% of viral suppress. So the global target of elimination of vertical transmission of HIV and syphilis by 2026 and AIDS epidemic by 2030. So by adopting this 95 95 95 rule, we can the global targets of eliminating this HIV that is to the year 2030, which is called as like generation zero year, that is called as generation zero, where the public platform for HIV treatment is removed and the private will be ongoing. So by 2030, the government and the WHO and the globally, all the organizations are seeing that it will be reduced. So the elimination is possible, but only if every obstetric encounter is optimized. Like to eliminate this, a triple elimination therapy, a triple elimination is considered. Like save this generation and the next with an integrated approach. We need to treat hepatitis B, HIV, and syphilis. As we know that when a patient is positive with HIV, HBsAg and HCV are the two infections which we encounter very oftenly. So when a pregnant woman comes to us, we need to test and treat for the mothers and prophylactic treatments and testing for the infants. And the syphilis, in the first trimester, the syphilis investigation, that is the VDRL, is must for all the patients. Then if the patient hepatitis B vaccine, the bird dose vaccine for the newborn should be given, and the testing and prophylactic treatment for the mothers to be considered. So NACP phase 5 says that elimination of vertical transmission of HIV and syphilis by 2026, that is this year, and integrated screening for HIV, HBsAg, and syphilis. Basics is like undetectable is untransmittable. Means if the viral load is less, then there is less transmission. There is less or no transmission. So if the viral load is less than 50 copies per ml, then it accounts for untransmittable. So U is equal to U, what is adopted, that is undetectable is untransmittable. So the basic things are test the patient, treat the patient irrespective of the CD4 counts, because many things that if CD4 count is good, then there is no treatment, but irrespective of the CD4 count, we need to treat them. Reduce the viral load as much as possible. Less than 1000 is considered as good, but less than 100 is considered as opt-treated. So prevent the transmission, mainly mother to child transmission. So all pregnant mothers should be screened for HIV and syphilis at the first antenatal visits. So the basic, the PITC, that is PTCT approach, provider initiate testing and counseling for all women as early as possible in pregnancy. CDC recommends the opt-out approach. So informed consent for the testing and disclosure must be in written. All testing to follow 5 C's, that is consent is taken, confidential should be maintained, counseling to be done, correct test result should be seen, then connection immediately to care the service. So by using all these 5 C's, we can treat a HIV patient or we can track a HIV patient. So retesting should be done for a high prevalence, like in case of any addiction patients and high risk behavior and HIV positive partners. So the screening for the screening is done by, the screening is done by two methods. The testing is done by two methods. One is a detection of antibodies and other is detection of viral products. So by antibodies, we all know rapid test, ELISA and Western blot, and virus is P24 antigen, which is most advocated, and DNA PCRs. So 3-test strategy, that is 3 tests should be done to say the result is positive or the negative. The first test should be highest sensitivity, followed by the second and third of the highest specificity. So when a pregnant woman comes to us, we need to screen for HIV and HBsAg whenever she comes to us, preferably in the first trimester. If she is negative, then leave her. If she is positive for HIV, then refer her to ICTC. If she is positive for syphilis, then treat her. If she is positive for both the things, refer to ICTC and also treat her for the syphilis. The same thing, when we are doing all these things, consider the sexual partner if there is any needle sharing, or treat them and test them and treat them too. The screening is repeated for all pregnant women with a positive, with a HIV positive. We need to retest them at 32 to 36 weeks. So the post-test counseling, when we are breaking the news, it should be very confidential and private and non-judgmental. Reassure the patient that it can be managed with good antiretroviral drugs, and it can reduce the rate of mother to child transmission by 1 to 2%. Then importance of starting the ART immediately, and adherence to that treatment is also important, as the patient needs to take the drug for a lifelong, for her life. So need for regular supervised antenatal care and common side effects of the drug should be explained. Safe sex practices advocated. So when the patient is in antenatal, we need to put her on if a positive patient comes to us, put her on a ART treatment. Then compliance and the viral of compliance should be seen, viral load should be seen, and the CD4 count should be detected. Then ART toxicity risk, that is antiretroviral toxicity risk of developing any disease should be seen. Vaccination should be given. All the vaccination should be given then plan delivery and breastfeeding accordingly the viral load and the CD4 count, and the infant should be followed up. So all these things will lead to reducing of HIV infections. So there are three phases, like one is antepartum, intrapartum, and postpartum. Among these three phases, the transmission rate is intrapartum is most high, whereas in antepartum, at the later stage of pregnancy, the transmission is there. But in intrapartum, 70% of the transmission is there. We need to handle this very properly and very aptly, so that the reduction of rate will be more. So in postpartum, it is always better to start a ART and prophylaxis for the baby so that we can reduce the rate of infection. So the factors which aggravates the mother-to-child transmission is recent HIV infection, high viral load, sexually transmitted diseases, maternal malnutrition, obstetric procedures, condition of the breast like sore nipple or cracked nipples, and preterm and low birth weight and oral thrush ulcers. So the risk of transmission from mother to baby. So if the patient is not on drug and she is breastfeeding, then the transmission rate accounts for 30 to 45. If she is no drug and no breastfeeding, 20 to 25%. If she is on drug with breastfeeding, 2%, and with drugs, no breastfeeding, 1%. So we need to counsel the patient for 3 drugs and no breastfeeding so that it accounts for only 1%. Then we can reach our goal by 2030. So now when the patient is there, again, U is equal to U, that is undetected, untransmittable. So for the patient, for the we start the ART therapy, so which leads to suppressing the fetal loading of antiretroviral drug, which prevents the replication of transmitted virus, and suppression of virus. Undetectable viral load will increase the immune system of the baby, hence prevent the transmission. So all pregnant and breastfeeding, ma'am, moving fast. All pregnant and breastfeeding women should be started on ART, irrespective of the duration of pregnancy, CD4 count, and the WHO state. ART should be triple drug and lifelong drug. So these are the few drugs that protease inhibitor, attachment inhibitor, fusion inhibitor, RT inhibitor, and integrase inhibitor. Among these drugs, nowadays, integrase inhibitor, that is dolutegravir, is the drug which is most important, and it is said by all the ART centers that start dolutegravir whenever the patient comes to us. So there is triple drug therapy. Dolutegravir is a must, which inhibits the HIV integrase enzyme, which prevents the integrate into host genome, which prevents the replication. So the next is, these are the side effects of the drug, as the time is not there. So the drug which is newer is dolutegravir, which has got a hepatotoxicity, weight gain, insomnia, and allergic reaction. So all other drugs, I think everyone knows about it. So coming to this, there are 5 stages according to the WHO HIV stages. The advanced stage has got like a pregnant lady presenting HIV with CD4 count less than 2000, and WHO clinical staging 3 or 4, children aged less than. This is the advanced stage. So the opportunistic infection, if the patient is having any opportunistic infection, then cotrimazole double strength prophylaxis should be given in a OD dose. So according to NACO-BIVA, that is NACO-BIVA means British HIV Association and Society of Medicine and Society of Fetal Medicine. Among these, we follow NACO. So the NACO says that at 6 months and 12 months after ART initiation, the testing should be done, and then every 12 months in a pregnant, once at 32 to 36 weeks of gestation. So, yeah. So, as I already said, if the viral load is less, then the transmission is less. If the viral load is more, it means that the patient is not taking any drug or the drug is not acting on the patient. So, we need to reconsider the therapy. So, next is the plan for the delivery. If the viral load is good and if the CD4 count is good, then go for normal vaginal delivery. If the viral load is less and if it is more than 1000, then if the CD4 count is less, then consider for LSCS. So this thing is important because whenever we do a obstetric intervention, good viral load, good CD4 count, then go for normal vaginal delivery. If the viral load is more, then if the CD4 count is less, then go for cesarean section. Always it is important for us to do the CD4 count and the viral load at 32 to 36 weeks of pregnancy. So all this safe practice and all, it is, we all know it. So I don't go for it. Then the scenario, that is the risk categorization of the newborn at birth, like all other things have carry a high risk for the transmission. Only if the viral load is less than 1000 copies per ml, then the transmission rate is less. So coming to the fetus, low risk and high risk category is there. If the baby is born to less than 1000 copies mother, viral load mother, then start the baby with nevirapine or zidovudine. If it is a high risk, then start the dual treatments. Both nevirapine and zidovudine is considered. So breastfeeding, it is advised for all the patients who are on ART treatment. So the replacement feed only if there is the criteria meet like acceptable, feasible, affordable, and sustainable and safe. So post-exposure, the needle stick exposure, which we all are worried is 0.3%, and perinatal is 20 to 40%. So these are the drugs and the regimes as the time is running up. So it is like 3 drug regime is given for all the patient when the patient is when the patient has been exposed. So 3 drug is considered, that is TLD, for a period of 28 days. So then elimination of vertical transmission of HIV syphilis is no longer limited by science or resources. It is limited by missed opportunities. So elimination of vertical transmission of HIV and syphilis is not a future goal, but a present responsibility. So test early, treat promptly, follow restlessly, and eliminate for the fever. And one more thing I add, madam. So India is giving 70% of antiretroviral drugs to the all other countries. So it's manufactured and it is providing more than 70% of antiretroviral drugs. So we need to be proud about this matter. Okay, thank you, ma'am.
Very nicely explained the HIV
Stop
in
sharing
pregnancy
that.
and
Yeah.
And
nice.
many slides are there, but only one thing need to be remembered, that viral load less, no transmission.
You and you equal to you. It was very nice.
Wonderful.
And the drug need to be added is dolutegravir, which is a recent drug, which triple drug therapy. This is the must, which is integrase inhibitor. So these are the 2 new things which I have found. Remaining all other things are same.
Yes.
And
One
Dr.
thing Sanjana Tallur
Yes, ma'am.
Beautifully highlighted the current protocol, the absolute necessity of the preventing vertical transmission,
yes,
and the holistic management required to ensure both maternal well-being and the healthy HIV-negative newborn. Both topics remind us how dynamic and the critical specialized obstetric care remains today. I want to thank
ನಿಮ್ದು
my
ವಿಡಿಯೋ ಹಾಕೊಳ್ಳಿ ಸ್ವಲ್ಪ ಇನ್ನ ಚೆನ್ನಾಗಿ ಬರುತ್ತೆ ವಿಡಿಯೋ ಆನ್ ಇಲ್ಲ ತಮ್ದು
ma'am, there are many injection
that's
drugs,
nice.
everything
Yes.
is there in the market which are coming now, but everything is taken after the ART treatment.
Yes, yes. I want to thank my co-chairperson, Dr. Ashalata Madam, and the organizers, all the organizers, FOGSI and Kasoga, Rajeshwar Madam, Shobha Gudi Madam, and Mane Madam, everyone. And these FOGSI and Kasoga webinar for putting together such a stellar scientific program. Thanks to audience for your active participation and questions. Handing over the floor to second session. Thank you.
Thanks, Suma. Thanks, Sasha. Yeah.
Thank you everyone. It was very
Thank you.
wonderful session. Yeah.
Before,
Thank you, Sajana.
Shobha, before it is concluded, we as doctors and obstetricians also should not be scared and should not hesitate to deliver, take care of the pregnant woman, because the transmission through this iatrogenic transmission is also very less.
Yes, sir.
Yeah, that is one thing. Even we are doing the laparoscopic procedures in these people. Once it is viral load is assured that it is low, so transmission is less. Even transmission through the bricks also is, as you mentioned, it is very low. Thank you.
Thank you, sir. Thank you, Pandit sir.
Even with these newer regimes, they are saying now that most of the patients are, when they test, they found them to be negative.
Negative.
Okay. Yeah, seronegative. And there is a lot of improvement with this new regime. So that has really made a difference. The only thing is what we have to be careful is, suppose if we have a very young girl and who is marrying a little elderly person, okay, and she conceives in first 3 months, we might we do the test, but it might come as negative because if she is in a window period. So it is better to repeat it again in third trimester,
Yeah,
or at least
it's a
consider 3
policy.
months
Correct.
as a window period,
Yes.
because the social and the behavioral patterns have changed in society now.
Changed. Correct.
So
Yeah,
we
Sheila,
may
even I
miss
agree
that
that
way.
it should be repeated once, especially if there
Guideline
is a
says that
surgical.
it should be repeated at 32 to 36 weeks.
Yeah,
Yeah, I think
that's
it
a
is
good
better we
message.
repeat. Yeah,
That is a good
I think
message.
that
Well,
way.
thank you very much. We move on to
And
the panel discussion.
one more
Dr.
thing I
Manohar,
observed,
please.
madam.
Yes.
Yes, madam. One more thing I observed, madam. When we do tridot, no, most of they do tridot only. Some of they are doing other things also. But the one who have got low viral load and their antibody titer very less, tridot sometimes it may not pick up. We have experienced
False
2-3
negative.
patients.
Yes.
It look very faintly. You should be very keen on them, madam. That
So
time
if
we
the
will try to
viral
go
load
for
is less than
confirmatory.
50 copies per ml, then it will be
Antibodies.
very faint.
Very faint and
Very
always
faint, or it may not be
technician will
present
come and
also, sir.
ask.
Correct. If there
Sometimes
is a
and
doubt,
that's
one can ask for a viral load and then proceed.
yes,
Yeah.
that is better.
Manohar,
And
Always
now
please
be
they
careful.
do the
introduce.
dual test also, no, where they
Hmm.
test for syphilis also.
Correct.
Yes,
Yes,
ma'am.
madam.
He
Yeah,
brought it
syphilis,
up very
usually it was
nicely.
not done
Correct.
before. Now we need to consider doing syphilis
Yeah.
in the first trimester along with HIV, HPSAG.
Yeah. Yeah.
It is
In the
Yes, madam.
private sector, it has been continued to be done. It was only in the public sector it had
public.
changed.
Government
Now I
protocol
think
is
it is.
not there, ma'am. We need to add
Yeah.
it right now.
Now it has to be added. Manohar, please introduce the panel moderator, please.
Yes, madam.
And
Thank
the
you very much, madam,
panelist
for
also.
wonderful.
And the panelist also. Yeah.
Yes, madam. I will
That was
try to
very
briefly
nice.
introduce.
Yeah, I agree with
It was
you
very
that the
nice.
talk was very good. Yes.
Talk was very good.
Yes.
Yes, madam. And we are going for second
Good
section,
talk,
anemia in
Shashila.
pregnancy and postpartum.
Thank you, ma'am. Now
Thank you,
I
madam.
listen Bellet, sir. Sir has got a huge history.
Yes, madam. Sir
I
is the
think
moderator,
everyone
Dr.
knows.
M.B. Bellas, sir. Yes, sir.
Everyone
Yes, sir.
knows me, so no
Good
need to.
evening, sir.
I
Good
am
evening,
happy.
sir.
I am happy that Shobha Gudi could catch him.
I hope.
So
I
in
get
brief,
you.
I am not that rare as Sheila Mane, madam.
I am
ಒಳ್ಳೆ ಮದುವೆಗೆ ಒಪ್ಪಿಸ್ದಂಗ ಆಯ್ತು ಇವತ್ ಬೇಡ ನಾಳೆ ಬೇಡ ಅವತ್ ಬಿಸಿ ಇರ್ತೀನಿ ಇವತ್ ಬಿಸಿ ಇರ್ತೀನಿ ಕೊನೆಗೂ ಸಿಗಾಕೊಂಡ್ರು.
yes,
ಥ್ಯಾಂಕ್ ಯು ಬೆಲ್ಲದ್ ಫಾರ್ ಕಮಿಂಗ್.
everybody knows Bellas,
Yeah.
M.B. Bellas, sir.
Namaste,
No need
Bellet
to,
sir.
he doesn't need any
Yeah,
introduction.
namaste. Bellet
Namaste,
sir,
namaste.
welcome. Welcome to the first
Ellargu
Kasoga
namaste,
address.
namaste.
Namaste.
Please, sir.
Please
Sir will be
introduce the
moderating.
panelist. Please
Yes,
introduce
sir.
the
We have
panelist.
expert panelist MC Metgood, sir, Geeta HS, and Dr. Arti Raghu, then Dr. Soumya Patil and Shobha Shavi, madam. So, as everybody knows, Mrityunjay C. Metgood, sir, is a professor in HOD, Department of OBG in JNMC Medical College, along with Bella, sir now. He has vast experience of clinical and surgical in obstetrics and gynec. Area of expertise, high risk and gynec onco surgery. Sir does fantastic onco surgeries, endoscopic surgery. He has a lot of publications, research papers, and a lot of contributions into the research. And he is he is a fellow of Indian Obstetrics Society of FIGO, as a past president of Belgaum Obesity Society and life member of IMA FOGSI and the AGOI Society and Menopause Society of India. Welcome you, sir, for today's session as an expert panelist. And one more expert panelist is Dr. Geeta HS, Professor and Unit Chief, Department of OBG at JJ Medical College, Davangere. She is trained in laparoscopy and ultrasound. She has a good experience of more than 20 years of teaching experience. She is a member of RGHS Board of Studies for 2017 and 18 and 25. DU Board of Teachers Award at she had a teacher award at IMA KSB and organizing chairperson of Society Zone and organizing chairperson of 5th State Yuva Kosoga 2025. Faculty at many states, and she has chaired so many sessions in critical care and medical disorders. Thank you. Welcome you, madam, for today's discussion as expert panelist. We have panelist. One more is Dr. Arti Raghu K. She is MBBS DNB OBG, PG degree in fellow in fetal medicine, and madam has vast experience in so many. Apart from obstetrics, she has fetal medicine expertise, super specialty, consult maternal fetal medicine at Dr. Krishnamurti Hospital, Bidar, since 20 years. Various position difficult organizations. She is secretary of Bidar Obesity Society, representative of Kasoga for Bidar. Now she is Obesity Society. She has member of perinatal committee, member of adolescent. So many members of community she has. Welcome to Madam for the today's discussion as a expert panelty. And we have one more.
Thank you so much, sir.
No panel.
Yes, Madam. One more is Dr. Shobha Dr. Soumya Patil. Madam is associate professor at Kalburgi MR Medical College. She has academics and she has her personal experience. She is associate professor there, and she has leadership in joint secretary at Gulbarga Chair Obstetric Society and secretary as a secretary. She worked as a secretary in OBG Society in Gulbarga, and she also worked as vice president and vice president twice. OBG like Obstetric Society in Gulbarga, past committee member of the Gulbarga Obstetric Society. So her area of interest is high risk and maternity, like maternal fetal medicine and infertility, gynec surgeries, and adolescent health. Welcome you, madam, for today's discussion as a expert panelist. Once again, one more last panelist is expert like Dr. Shobha Shavi. She is consultant at hospital, Sanjeevani Hospital, Ilkal, Bagalkot. She was past secretary of OBG Society, Bagalkot, past secretary of Critical Care Committee, Kasaga, chairperson of Safe Conservative Committee, and presented many papers at national, international levels and conferences, conducted many, participated in many CMEs and webinars, and got prize awards in AICOG Lucknow, Jagadishwari Mistra Prize Award, conducted many awareness programs at when she was in the secretary in the Bagalkot Society. I am a part of that society. She won a prize for poster presentation in Kasagat Conference 2022. Her area of interest is fetal medicine, recurrent pregnancy losses, then obstetric medicine and critical care, and non-descent vaginal hysterectomy, then preventive medicine and holistic health. Welcome you, madam, for today's discussion as a panelist expert.
Thank you, sir.
Please, mic to all four of you, and sir will be the moderator, M.B. Bella sir, as you all know. We all are, most of us are sir's students.
Yeah, that's what I
Welcome,
thought.
sir.
It will be a class.
Yes,
And
yes.
I had just one observation to make, Bella. You have really strong panelists today, and it will be very
Yes,
interesting
yes.
to watch this
Very
panel.
interesting topic,
Yeah.
Animan.
Thank you. I think
And one
somebody
more
has to allow.
observation. Everybody's pictures are superb on the CV. All of you are
Yes.
looking very good. So this is a new phase of Kasoga, I must say. It is emerging very strong. And Suman, you have got a very bright Kasoga coming to you.
Can
Thank you,
somebody
madam.
allow
Thank you,
me to
madam.
share my
Yeah,
presentation?
Please.
please make him host. Yeah, please go ahead, Balla. The field is yours. Yes.
Can you see my presentation?
Yes, sir.
Yes, sir. We are seeing, sir, visible and audible also.
Can you see the full screen now?
Yes, sir.
Yes, sir. Yes,
Yes,
sir.
sir. Full
So I-
KLE Medical College we are seeing, sir.
Yeah, and the hospital, madam. I'm very
Yes, sir.
happy,
Also.
and I sincerely thank the FOGSI, ICOG, and Kasoga for giving us the opportunity to have today anemia panel. You all know that why we are taking up this. So let me go through this. So thank you so much. And these are my expert panelists. And I just want to say that these how the outline of presentation would be under these headings. And the impact of anemia, iron deficiency. Can I just take it? Impact of ID, that is iron deficiency anemia, and in general anemia in a woman of reproductive age group. You know that it has so much negative and adverse outcomes. It causes fatigue, decreased cognition, diminished physical function, suboptimal development, poor quality of life. And these are the preventable deaths. You please note that these are the two things we should be. From 560 in 1990 to 87 we have come, and further reduction is challenge. And unfortunately, for the last two MMR bulletins, Karnataka has increased from 58 in 2020 to 2022 to 22 to 24 we have gone up from 58 to 73, which is not a good sign. And if we want to reduce further the maternal mortality, we need to approach these things. This is the global prevalence. You can understand where we stand. And prevalence of anemia, it is known. I am putting the first question to Dr. MC Metgood. Good evening, Metgood. Are you there?
Yes, sir. Yes, sir. I'm very much here. Yeah.
Yeah. Can you explain what has happened in NFHS 5, that is 2019 to 20, compared to NFHS 4? Here, I just want to bring to the audience notice that in NFHS 6, which came up in May, did not include anemia because what were some of the errors were there in NFHS 5. And this, they are going to bring a separate nutritional fact sheet, which will be published later. So, Metgood, can you highlight on what changes happened in NFHS 5 to NFHS 4?
Yeah. Thank you, sir. I hope everyone is able to hear me.
Yes,
Are you able to hear me?
Yeah, very much,
Yeah.
Metgood,
Yeah.
very much.
Yeah. Yeah. Yeah.
Yes, yes.
So,
Audible.
by these particular surveys, what was found is from the 4th to the 5th NFHS survey, basically, they found that anemia across all age groups, across pregnant as well as non-pregnant, as well as men, right? The incidence of anemia was more. This what was the basic thing that was seen in this NFHS 5. So even children under 5, it was increased dramatically, almost 5 to 10%. Every 2 out of every 3 children under 5 in India were found to be anemic. Even in women, it was increased. In teenage girls, it increased, as well as it was also found that even in men, it had increased, the incidence of anemia from this particular survey. So, of course, it was even more in the rural population, the rural women, as compared to the urban women. And there were two states which it was the highest, not that it was less in Karnataka, but to lead where Bihar was one of the states which was almost 63% nearly. And next to it, almost equal was Gujarat. So these were the two leading states, and Karnataka stood at around 45% approximately. So overall, what was found was a general trend in the increase of anemia across all age and sex.
Fantastic. You all notice that, the anemia from NFHS 4 to NFHS 5, it increased in all what Dr. Metgood told. It has an important bearing. I am now going to ask Dr. Shobha, what are the important maternal effects and pregnancy outcomes due to anemia in pregnancy?
Good evening, everybody. I thank Dr. Shobha Gudi Madam for making me part of this. Coming to the effects of anemia and on the mother, anemia can have many adverse effects on the mother. First of all, she won't be able to enjoy the pregnancy completely because she's always tired and breathless and maybe having so many emotional and cognitive problems. Other than that, she can have preterm labor. She can have repeated infections because of decreased immunity. She can have repeated UTIs, repeated vaginal infections, which can in turn lead to PROM and preterm labor. And during labor, she can go into failure. She can have delayed delivery, and she will need a lot of assistance during labor. And after delivery, she can have sepsis. She can have PPH, which is very, very important. And during pregnancy, she is also at a high risk of developing PIH. And PIH, along with anemia, is a very, very grave situation to handle, increasing the mortality in these patients. And after delivery, she can have PPH, she can have sepsis, and also there is failure of lactation, and even her fetus can have many side effects like decreased FGR and preterm delivery, low birth weight, which also can cause a lot of complications in the further life of the baby. And this baby is more prone to anemia in the future. And baby can also have a lot of cognitive and neuronal problems also.
Doctor, I think she highlighted very nicely about the pregnancy and the during the maternal effects and the fetal effects and neonatal effects. Please understand, this is a very, very important situation. And I now like to ask Aarti, Raghu, and others how anemia causes postpartum hemorrhage, because this is a real challenge, and Aarti would definitely make it very simple. Aarti, are you there?
She's muted, sir. She's talking, but
Hello, sir.
Yeah.
Hello. Good evening, everyone. Thank you for making me one of the panelists here. Thank you so much. Sir, actually, after PPH, women become anemia that we know, but anemia increases the risk of PPH. It has actually three reasons. First of all, in anemia, there is reduced hemoglobin, and it causes activation of hypoxia sensing cells in the aorta. It activates sympathetic nervous system and thus it increases heart rate and stroke volume. Because of increase in heart rate and stroke volume, the blood loss is more from the bleeding blood vessels. And also in anemia, there is reduced RBCs, and because of that, viscosity is reduced. And because viscosity is reduced, blood becomes thin and it flows very fast and easily from the bleeding vessels. And third reason is RBCs. If the RBCs are more, then the fibrin clots are resistant to fibrinolysis. But when the RBCs are less, these clots become very susceptible to the fibrinolysis and there is more bleeding. And thus anemia causes PPH.
Soumya, can you add on this? What are the other effects of anemia which cause PPH?
Yes, sir. Good evening, everybody. Thanks for the opportunity, sir, and Shobha Gudi ma'am and Rashmi Palladi ma'am. The other added causes could be due to increased fibrinolysis of the blood clot that are formed in the anemic patients. Because in anemic patients, because of the decreased hemoglobin and RBCs, the RBCs which provide resistance to the fibrin blood clots to undergo fibrinolysis is decreased. So that is the reason there is increased fibrinolysis. And also there is another mechanism which disrupts the laminar flow. So what is this laminar flow? There is in a normal blood vessels, when the blood is flowing, usually the red cells are concentrated in the center of the vessel and the platelets are at the margin towards the wall of the vessel. This is called as laminar flow. So in anemia, there is disruption of this laminar flow and these platelets are not there near the margin of the walls, which causes or prevents the blood loss by forming platelet plug. So these are the other added mechanisms which will. Thank you, sir.
Yeah. Yeah. Can you, Geeta, highlight on another important mechanism?
Good evening, all of you, and I will thank Shobha Gudi madam and Bellat sir for giving this opportunity to participating this panel. So definitely iron deficiency anemia increases the risk of the risk and worsens the consequences of the bleeding after the childbirth, because this idea will associated with the poor uterine muscle function. Why means because severe anemia will reduces the oxygen delivery to the all the tissues, including the uterine. This oxygen depriving uterine will lead to the less contract. It will act less. It will contract lessly. So it will lead to the uterine atony. That's why it will causes the PPH. And anemia will also lead to the prolonged labor, and it will also associate with the infection, which will again it is the risk factor for the uterus atony. Again, it will causing the BPH. And sometimes this severe anemia will associated with the impairing the normal function of the platelet, which will lead to the it will affect the impair the normal clot of the platelet distinct. Along all with this, patient will be having the reduced tolerance to the blood loss because of anemia. So it will again increase the PPH. So So iron deficiency anemia contribute to PPH mainly by
You are unable to hear. So you all know that there are
hello.
hello. There are different mechanisms by which, most importantly, anemia itself is a cause for PPH.
PPH, yes, sir. It
Mechanism.
usually causes the uterine muscle.
No, myometrium is also having myoglobin, which has an iron. If there is a deficiency, that this myoglobin is not properly formed, and these enzymes also require iron as a catalyst, and these are the deficiency of these will affect the intracellular mechanisms.
So all this will lead to the PPH.
Yeah. So you understand that why we should treat the pregnant woman before she goes into labor. Very, very important. Dr. MC Metgood, can you tell us what are the important causes of anemia?
Yeah, as we all know, basically one of the important causes is nutritional, and the other one is genetic, like hemoglobinopathies, and there are some other causes. So basically, the iron deficiency anemia is the most commonest type of anemia. And apart from the iron deficiency, there could be the zinc, the folic acid, and B12 deficiencies that are also there along with iron deficiency anemia. And apart from this, the hereditary or the genetic hemoglobinopathies like the sickle cell anemia and also the thalassemias are also some important causes of anemia, even though the leading cause worldwide is the nutritional anemia due to iron deficiency anemia.
Can you please tell the important roles of the iron, and is there a vicious cycle which we need to break?
Iron is such a micronutrient that it is almost essential in every part of the body and every cell. So iron is involved in the physiology and functioning of every cell. That's what is the basic truth. And right from erythropoiesis to cell proliferation and growth, it is very important. And uh, it involves everybody, right from infancy to adolescence to adults, the pregnant woman, the non-pregnant woman at birth. So that's how it can affect at different levels.
So a very important point you brought up. See, we in India, what happens is by birth the baby is anemic, as it was mentioned, and when the anemic baby, because breast milk is deficient in iron and other important components, and if there is a insufficient transfer of this during the cord, through the cord to the from the mother to the baby, infant will be anemic, adolescent will be anemic, same become adult, and she becomes pregnant. So this anemia vicious cycle is there. It is happening since generations. Should we break or no?
Definitely, we need to break this cycle, sir. And that's why the government programs are also right from school age. There is, iron supplementations being given. The pregnant woman iron supplementation is being given. So prior to pregnancy also it's very important. So basically to break this cycle, I think even though even if it cannot be done from that particular age of school age, but at least prior to anybody getting pregnant, I think they should be correcting their anemic status and then plan their pregnancy. And of course, when they come with pregnancy, the early initiation of iron, early second trimester should be our aim
Yeah,
in
I
breaking
think
this
it's
particular cycle.
Yeah, wonderful. See, the importance of this is that is why government has brought up 1,000 days. During this 1,000 days, that is pregnancy to 70 days and 730 days of the first 2 years of life, where the organ system is forming and program is happening. So here we need that woman should be very, very healthy at the time of entry to the pregnancy and during pregnancy as well as after the pregnancy, and their baby should get the maximum the nutrient transfer in the form of antenatal transmission through the cord. So this is very essential. As we have observed, we will come to that little later. What should be the level at which the cord blood should be having even after giving 1,000 milligrams of IV iron? It did not happen. I want to highlight that little later. So please, Dr. Shobha Shavi, can you please define and explain the degrees of anemia,
Sure.
explain the dilutional effects of pregnancy, and what is the additional requirement of iron in pregnancy?
Sure, sir. Anemia can be defined as a hemoglobin level of less than 11 in pregnant women. The dilutional anemia of pregnancy happens because in pregnancy there is increase in volume of plasma of around 50%, whereas the increase in RBC mass is around 30 to 40%. Hence, there is a dilutional anemia which happens. It's a physiological effect and it helps in increasing the blood flow to the placenta and also helps in tolerating PPH during postpartum period. Anemia can be classified as mild, moderate, severe, and very severe according to ICMR. And mild anemia is 10.9 to 10. Moderate is 9.9 to 7. Severe is 6.9 to 4. And very severe is less than 4. Whereas WHO classifies it as mild, moderate, and severe, where mild is 10.9 to 10, moderate is 9.9 to 7, and severe is less than 7. The iron needs of a pregnancy is around 1,500 milligram in a healthy non-anemic woman. In that, 500 mg goes for the increased hemoglobin production. 500 mg is for the fetus and the 300 to 500 is for fetus and placenta. And the loss during postpartum period is around 200 and daily losses of around 200 if we add to that. And also the lactational need for anemia, it will be around 1,500. If we don't consider that, it will be 1,000 milligrams.
Dr. Arti, do you think that that was a right way of correcting the anemia? Do you think diagnosis is a challenge? How can we diagnose? What is the iron deficiency and iron deficiency anemia? We are mainly concentrating on the bigger aspect of cause of anemia is iron deficiency. Can you highlight on that, Arti?
Yes. Yes, sir. Actually, for diagnosing anemia, we need to do complete blood count. Along with that, we need to do serum ferritin levels, then TIBC, transferrin saturation, and serum iron also we have to do. And along with that, we have to see whether it is just iron deficiency or megaloblastic anemia, or it is any hemoglobinopathies. For that, we have to do high performance liquid chromatography, and it is compulsory test in pregnancy, I must say. Uh, in complete blood count, usually we see less hemoglobin. As Dr. Shobha ma'am told, it is less than 11 grams, we should consider it as anemia. And in ferritin, ferritin shows the stores of anemia. Actually, means what are the iron stores in our body? Those are reflected by serum ferritin, and it is very good, very specific and sensitive marker. And if both hemoglobin and ferritin levels are less, then sure shot it is iron deficiency anemia. And if the lady is found to have thalassemia or other hemoglobinopathies, we have to get her husband tested with HPLC. And if both are carriers, then we need to do the test for fetus, and we should avoid the birth of thalassemia major babies in such conditions. And serum ferritin, it is very specific and sensitive marker, and anything less than 30 nanogram per ml is considered as depleted stores. And sir, I want to tell one thing. Now we are, even if the lady's hemoglobin is normal, we have to see how the stores are actually by doing ferritin, because it is like another extreme level of spectrum from normal to iron depletion, then erythropoiesis hampering, and then iron deficiency anemia is the last stage. We have to catch this lady in early stages where we should address iron depletion also, because on mother's serum iron level, even baby's iron stores are dependent. And we should avoid babies with iron depleted state to get born, because again they will be having complications postnatally. Till 2 years of their age they will be having repeated respiratory infection, and they are susceptible to other infections. Their growth is retarded. So we have to differentiate between iron deficiency and iron deficiency anemia and address to the mistake.
Yeah, very nicely brought out. See, there are two different concepts, iron deficiency and iron deficiency anemia. Iron deficiency anemia is a severe spectrum of this. So iron deficiency is there. There is a store deficiency. Women may not be anemic, but she cannot transfer adequate amount of iron or the nutrients to the baby. So this is a very, very important if you don't want the baby to be anemic. Earlier, when we were students, we were taught that baby does not suffer. It is a parasite. It will extract from the mother. It is not so. There is a deficient transfer of this iron to the baby, and it has its own impact on the neonate as well as during the feet as a pregnancy. So, Dr. Soumya, what are the principles of management of anemia?
Yes, sir. The management includes both prevention as well as treatment of anemia. Prevention in the sense we have to prevent the occurrence of anemia well before the patient or the patient tries to conceive, especially by supplementing iron supplements for the teenage girls or the female who's trying to conceive. First check her hemoglobin levels, see whether if she is anemic, and then treat her anemia and then ask her to conceive and enter the pregnancy with the proper hemoglobin. And also postpartum management is equally important because the mother who has lost the iron stores during the pregnancy and delivery have to be adequately replenished before she goes into the next pregnancy. So the postpartum management with iron supplementation for the 6 months and also with the proper spacing is important, sir. And then treat the underlying causes, like the common causes are due to nutritional deficiency, ask her to take adequate nutritional iron-rich diet, and also causes like worm infestation, the regular deworming should be done, or if there is any chronic blood loss like in hemorrhoids, it should be treated. And then advise or educate her about the iron-rich foods. Both non-animal based foods and non-animal based foods are there. The animal source being the meat, chicken, cattle, fish, and poultry. Non-animal foods are legumes, green leafy vegetables, figs, dates, and jaggery. The most important jaggery, which is dark in color, not the whitish which we are getting now. It should be prepared in the iron vessels. And then there are certain factors which will affect the heme iron absorption. We have to ask her to avoid the intake of the iron supplements along with the calcium, tannins, tea, coffee, herbal drinks which will prevent the absorption. And the factors which will favor the absorption are protein, meat, fermented foods, and the gastric acid. And also in women who have low iron stores and increased erythropoiesis itself will influence the absorption.
Thank you. That was a very nice elaboration on the management. Dr. Geeta, what are the modalities for treatment of iron deficiency anemia?
While treating the anemia, we have to, along with the correction of iron deficiency anemia, we have to reserve the iron reserve also. We have to restore and we have to treat the complications of the anemia also. This choice of therapy depends on the severity of the anemia and duration of the pregnancy, that is gestation of the pregnancy, and associated complicating factors are important. So usually there is the oral preparations are there and parenteral preparations are there and blood transfusion. Usually blood products are packed cell we are transfusing.
So, Dr. Metgood, what are the challenges of oral iron? Since 1964, we are giving oral iron. What do you think it is? Dr. Metgood?
Sorry, I was muted. Yes, sir. As rightly told by you, I think it's been decades that we have been trying this oral iron, and even now, if you see, it has not made much of a difference. Uh, if you see our trials to the rapid iron as well as the postpartum priority trial, what we found is one of the most important things and interesting thing is the compliance aspect of it. We have very interesting things happening as far as the compliances are concerned, because these were being closely monitored in our studies. And just to give you in a few sentences, uh, the women who were given these iron and folic acid preparations, these tablets were not taken at all, because every bi-weekly we used to monitor them, telling them to show the strips that have been emptied. They were either not taken properly. That's a different aspect of it. But the interesting that things that used to happen is they used to keep it below the pillow, or they used to suddenly when we went to check them, they used to take out the tablets and throw it out of the window. Um, More interestingly is, her sister, she was feeling giddy or something like that. So this lady gives these medicines to some of her friends or to her sister for these purposes. So compliance is one of the
Challenge. Important
challenges
challenge.
that, yeah, that's right, sir. So compliance is one challenge. And the other things is, of course, the side effects that are noted with these oral preparations, including, the bowel disturbances, like it can be constipation, it can be diarrhea in some, and abdominal cramps. Some people have, some of them have the black stools and they are worried about it. And so, due to these things, the GI side effects, the intolerance that they have due to these oral preparations, uh, it's a real challenge. And also, of course, nowadays there has been a role of these hepcidin that has been noted and
Implicated on this.
implicated on this. Yeah. So
Yeah,
these are the oral challenges.
yeah,
These are the challenges
definitely.
with the oral preparations. Sorry.
Very nicely brought up and summarized. See, intolerance, and please also note method of administration. See, we need what just someone told that Aarti, I think, says 1,000 to 1,500 required. Can we meet with the oral iron? If you give everyday iron, it won't get absorbed because it comes later on. We are coming up, and if you give alternate day or twice a week regimen, we cannot cover all the meat. If you give very high dose, there will be side effects and intolerance, and the compliance challenges are associated, which are nicely brought up, Metcud. So why you think we need to have parental iron?
Yeah, the reasons have already been enumerated. The first and foremost is our vast experience for decades that oral iron has not helped. Second is all the challenges with the oral iron that I already mentioned. That's another reason. And all these can be taken care of probably by giving IV iron infusions, especially nowadays the injectables are quite safe as compared to what were in the past. And just one shot of iron up till 1 gram or even up till 1.5, they say is good enough to increase the serum iron levels and the storage to such levels that can be maintained in pregnancy and delivery.
So you know that the hepcidin concept which has come up. See, the importance is, see, this is iron regulator. What happens is whenever there is iron you are given, today you are given, the iron levels will be increased in the blood, and that increases the hepcidin, which prevents the iron absorption from the body. You can see here, look at what conditions will increase the hepcidin and what conditions. See, a low iron erythropoiesis and hypoxia, they suppress the hepcidin secretion from the liver. Whereas those with high iron inflammation, and that's why chronic infections, why there is a anemia is because iron is not absorbed even when we give, because these increases the hepcidin level and that prevents the iron absorption and they continue to do that. So everyday iron is really not, and it is a challenge. And please understand the importance of this hepcidin, and these are the agents which increase and reduce the hepcidin level. Dr. Arti, do you feel parental iron is important?
Yes, sir. Parental iron actually is important because as there is increased need of iron in pregnancy, and she has so many side effects, problem with the compliance, gastritis, and other things. And if the lady is on ecosprin, again the gastritis level is increased. So we have to be reliant on parental iron because we can give high doses up to 1 gram. We can give at a shot, and even with parental, we are sure that she's taking. We are not dependent on the lady that she's taking or not, she's compliant or not. And also in pregnancy, we see the absorption of food, and even iron rich food also absorption is less because of many enzyme deficiencies. And again, we know of this hepcidin effect also. And because of that, parental iron is very good way of covering her iron deficiency. And now these iron preparations are very safe, and every day we are using. There are no anaphylaxis as such. Minor side effects will be there, but that can be managed. Parental irons are the best things in our armamentarium, I think.
So you know that why we need parental iron, and one important thing is we have administered and it is safe. And please understand, compared to first generation, the second generation and third generations are safer. So we can give single dose in the third generations. These are the 4 or 5 the single dose
Formulations.
available, you understand, and out of these only we have 2 of them available in India, Fermoxitol and low molecular iron dextran. They are available in USA, and these two are available in India. Iron isomaltoside is available from the 2 companies, and ferric carboxymaltose is multiple because it has taken away its patency. So please be careful about the very cheap drugs which are marketed coming from somewhere, and these are associated with very horrible side effects, including reactions, pigmentation, discoloration of the face and all. So be careful, use the standard ones which are having age-old impact of this. So please understand this can be given 20 milligram per kg or maximum of 1000. If can't, you can repeat it at the later part. Dr. Geeta, can you tell us why parental irons are covered by carbohydrate? You looked at the iron sucrose, ferric carboxymaltose, iron isomaltoside, or ferric derisomaltose it is called now. So can you tell the different iron preparations and why it is covered with the carbohydrate moiety?
Because free iron is highly reactive and usually it is potentially toxic. These free iron are generate reactive oxygen species that will cause us the oxidative stress and it will damage us the tissues. So carbohydrate shell binds the iron tightly and prevents the sudden release of the large amount of iron into the bloodstream, sir. And it
Yeah.
controlled release of the
Iron, elemental iron. Very
iron.
nice.
Iron carbohydrate complex. It takes up by the macrophages in the liver and spleen and bone marrow, sir, by reticulocytes. So it will slowly release to the stream, sir, bloodstream,
Yeah,
sir.
Yeah.
they are
Dr.
unstable
Bellat,
actually.
Dr.
Elemental.
Bellat, we still have time. We still have more.
I want to highlight few more important ones. These are the
Yeah,
different operations I'm
yeah,
pointing out.
correct.
These
We
are the
have
just
already
names we
done
are given.
50 minutes. So yeah,
Yeah.
you can take another 5 minutes, sir. No problem.
Yeah.
Yes,
What
sir.
are the contraindications and prerequisites to ensure safe administration? This is Dr. Soumya.
Yes, sir. Known hypersensitivity to the drug is definitely a contraindication, and anemia that is not caused by iron deficiency. So before giving iron parenteral iron, we have to confirm that it is due to iron deficiency and not due to any other genetic genetic causes for anemia like hemoglobinopathies. Then iron overload or disturbance in the utilization of iron like in hemosiderosis and hemochromatosis. And in first trimester of pregnancy, though there are no studies which have proven that it is teratogenic, but still there is limited data or there is insufficient evidence to safely use during the first trimester. And also acute and chronic infection is a relative contraindication, sir. We can defer the treatment until the infection is treated. Then active autoimmune disorders and also any contraindication which is specific to the drug.
Drug. So please understand where it should be administered when the trained staff is available and
Yes.
resuscitation facilities are available to avoid. Otherwise, we face the consequence of what happened in one Bangalore doctor's incident. So even
Yes.
you may be expert, cannot take it home. So parental iron, important message is don't just give irons, give additional supplements which are essential like vitamin B12, folic acid, zinc, and high protein diet. Dietic support is very important. Most importantly, proper counseling. Mild body ache may be there, fever may come up, and a little bit initial tightening, chest tightening will be there. You can stop that and restart and give it completely. So these are some of the minor side effects. Dr. Shobha, can you highlight? This is the message I wanted to give, Shobha Goody madam. The effects on fetal and infant brain effects of iron deficiency.
Yes, sir. What we should understand here is iron deficiency can have a permanent effect on the rapidly developing fetal and infant brain. There is it is seen that there will be demyelination and decreased synaptogenesis and neurotransmitter synthesis within the prefrontal cortex, hippocampus, and basal ganglia. This can lead to lasting neurodevelopmental deficits, including lower IQ, poor attention, and motor delays. So there can be abnormal neonatal brain functions. Many studies have been done which show that there is a wide range of motor and cognitive deficits while infants are iron deficient. The
So the
neonatal
important message, Shobha, is unlike adult iron deficiency, early iron deficiency results in neurodevelopment alteration that persist despite of repletion. The point is, if you once the damage has happened, it's difficult to correct once, even though we correct the iron repletion. So very important point you brought up. See, this is how we want to say here is if the pregnant woman has adequate iron storage, her baby's brain development will be iron sufficient baby receiving. This is the type of neuronal development. If the iron deficient, this is the type of neuronal development. So please note that it is a very, very important message, Shobha, you have conveyed. Dr. Metgood will be, because he has done the postpartum anemia trial on priority. Can you briefly highlight on the priority study? You are muted, Metgood.
Sorry. This was one of the global networks NICHT trial. It was a multi-country trial and it was a randomized control trial. And this was basically in the postpartum anemic women. And the eligibility was basically those who were moderately anemic. So they were the ones which were enrolled into this particular study. And one was with the, one arm was the FCM, 1 gram, and the other arm was the standard oral iron therapy. Oral iron therapy. That's right, sir. So some of these women also did have the ferritin levels done. They were also looked in for the safety aspect of it, that is hypophosphatemia. That's the main thing that was looked for here. And what was found is that a single dose of, and in this particular trial, as we said, that injectables are not that safe. So we had a particular checklist for every lady, wherever they are going to be given this IV iron infusion. There was a checklist, and that checklist used to be checked every time it was given, and made sure that every emergency drug and all the requirements are there in that particular room where these IV transfusions were being made. So we also did an official training of this IV iron infusion we had made videos, and we went for the training to each of these sites in Africa, in South America, and India, and made sure that they follow all precautions before these transfusions were being made and during transfusions too. So what was observed was that one single dose of IV iron did make a difference in improving the hemoglobin percentage, and the hemoglobin more than 11 and more than 12 were taken into account. And they did find that in our study, it was found to be beneficial, even though we have still not published it. But the results, I can tell you in brief that FCM arm did improve the hemoglobin and the ferritin levels in these postpartum women who were moderately anemic.
Thank you. That was very nice, brief presentation on priority. But I just want to add on this is in moderate anemia in pregnancy, when we gave 1 gram, it did not sufficiently cover. And when we noticed this, that even though oral iron, there was non-responders in our arm, IV iron and versus oral, those who did not respond and those went needing the rescue therapy, that is 7 grams and below, they went. We had to give them, as per the ethics concerned, IV iron for them. But what happened is when they received this in anemic woman, even 1 gram was not sufficient, which was evident that after 24 hours, 24 weeks, the iron levels came down as that of the others. And secondly, the cord blood, the iron level, ferritin levels were less than 75, which it should be above 80 picograms, but it was less. So indicating that we need to add up the later in pregnancy 1 more dose in anemic. If non-anemic, it may be probably sufficient to cover because the store depletion. So I just want now others to give one important message, one message from each of the panelists, starting with Metgood or Shobha.
One message is I think anemia is a major problem in women and even in men, and we have to concentrate more on women. And what needs to be done is to prevent anemia. That's the first thing. And the second thing is the testing has to start prior to they getting pregnant and see whether they really are anemic, correct the anemia, and then plan for their pregnancies. And even during pregnancies, emphasis has to be made on iron supplementation, and the compliance needs to be really looked into, which is a major issue. And if they are not tolerant or if they are not compliant, we have to see that they receive the injectable iron, whatever is available.
Yeah, important is preconceptional care and strengthening the prevention of anemia. Next person, Shobha.
Never miss a chance to diagnose, test for anemia, and counsel the patients regarding the diet and also the proper treatment. Be it a young girl who comes for irregular menses or a newly married woman who comes for repeated UTIs or honeymoon cystitis. Like any patient you once come across, you test them for anemia. If she is anemic, treat them properly, completely, and also counsel them regarding the side effects of anemia and the importance of having a good hemoglobin before starting your journey as a mother.
Yeah, Shobha, that is you want to convey 3 T's: test, treat, test, talk, and treat. Very important. Next person.
Hello, sir. Myself, Dr. Aarti. I want to tell that in pregnancy, we should get a high performance liquid chromatography for each woman at the booking visit itself. HPLC. Yes, sir. And we should screen for thalassemia. We have to prevent the child with thalassemia major. Yes.
Hemoglobinopathies. Very good message.
From being born.
Yeah, because we have done a study which is shortly coming up in CFOG. 10%, almost 9 to 10% of our pregnant women are having some form of hemoglobinopathy. Next person, Dr. Geeta.
Yeah. We have to screen first to the antenatal visit only. We should not wait till the second trimester, sir. and we have to repeat the hemoglobin level as and when we require. When we are doubtfully clinically, we feel like patient is failed, we have to repeat the hemoglobin.
Yeah. Especially eligible couple when their survey is happening in government setup, that should happen in pre-conceptionally. That is where we should treat, because we cannot give iron preparations in the first, though you are recommending some guidelines, but we, as far as we have the evidence, there is no recommendation of use of iron in the first trimester, because it is not a safe drug in the first trimester as per the FDA classification. So please understand that early pregnancy treatment is very important, and test. Very good point. Screen the woman. Next, last person, Dr. Soumya.
Sir, we have to educate and make the medical officers at the PHCs aware that on repeated parental iron supplementation, which is given free of cost at the government setups, there is no improvement in the HB. They have to be referred further for the further investigations and check for hemoglobinopathies. We have seen so many women who have been having hemoglobin less than 8, 7, continuously receiving iron preparations without evaluating further. So we have
point
to
is
educate
to
them.
highlight, apart from anemia, also there are other factors like vitamin B12, folic acid, and with zinc and all. These need to be also, and evaluation is important for the hemoglobinopathies to identify you. Last, anyone is left? So if we have done with that, these are the points which I want to conclude, stating that treat anemia before she becomes pregnant. Prevent anemia for prevention of anemia-related complications in pregnancy. If we want our next generation to be smarter and intelligent, their mothers should not be anemic or iron deficient, and other nutritional deficiencies also need to be corrected before they become pregnant. Prevent anemia at every level. Let us make anemia-free India and achieve SDG goals well before 2030. Treat anemia, iron deficiency, and she should not be anemic. This is the message. And I just want to thank everyone, especially Kasoga team, Dr. Shobha, Dr. Sheila Mane, and ICOG FOGSI members for providing. And I thank sincerely panelists. I hope I have given adequate time to you people. Sorry if I am cutting it only because of the time. And ensure healthy baby and smart and intelligent baby. Prevent anemia. Thank you so much. And this always I convey this video, that is communication and counseling is very important. Otherwise you will get beaten like this. So proper counseling, infusion has to be safely done. Any IV preparation, antibiotics, drugs, including vitamins, are known to cause reactions. IV iron is no exception. So let us prevent anemia at every stage and make this anemia free, anemia mukta Bharat. Thank you so much.
Yeah, can you stop sharing, Arun? Dr. Bennett, please stop sharing. Yeah. Yeah.
Good evening, everyone. Shobha madam.
Yeah, I just wanted to compliment Dr. Bennett for the
Okay.
wonderful panel. I'm really thankful that he took the effort to share the information with all the panelists as to the direction of the discussion. And I think each and every panelist did full justice to the content shared to them. Very nice inputs by the panelists. Really proud of Kasboga today. So many thinking minds are there, and so much potential is there. So thanks all of you, Aarti, Soumya, Shobha, Geeta, and Dr. Metgood. Wonderful. I think Dr. Metgood, it was very nice to hear you speak actually. And you have a very impressive voice, sir. Especially you're muted. For a webinar, a strong voice is very much required. Sir, you're muted, sir. I can't hear you.
Thank you so much, madam, for the appreciation.
Yeah.
Thank you so much.
Thanks a lot. And the two speakers also did well, Sanjana and Rajeshri, and very, very nice talks, and also the chairperson. So thanks everyone. I must hand over to Shobha Bembalgi because she's the
Madam,
treasurer, the official vote of thanks. No, no, you must
Madam, you
thank.
Madam.
Thank you so much.
Okay, Madam.
Never
Good evening, everyone.
Sorry.
I thank FOGSI and ICOG committee for giving us this opportunity to conduct this CME. I thank today's guest, Dr. Bhaskar Paul sir, FOGSI president, and Sheila Manam for being our guest. I thank Dr. M.G. Ramat sir and Nagraj sir, our honorable guest. I thank our president Rajeshwari for giving the valuable input. As usual, I thank Shobha madam for conducting this CME in very nice way, madam. And it was really very helpful. And I thank all our incoming president Shobha Suman for being with us for all time. And I thank all the speakers who really we didn't know, we did not miss a single minute also for today's CME because all three topics were very interesting. I thank Rajeshwari for giving input about the obesity and management. Sanjana, our own friend, it was an excellent talk what she gave about the HIV. And note, second thought about Ballat sir. He moderated the session so well, and all the speakers were really have given us a very good input about the management of anemia. And I thank Medkut sir, Shobha, Geeta, and all the speakers. And I should not forget to thank our MOC Tansale, who really did a good job. And I thank our chairperson.
Manohar, thanks a lot, Manohar.
Yeah,
Thank you
madam.
so much, madam. Actually, I should thank you. You guided me from ABCD. Today, one day I disturbed it a lot.
Thank you, Asha madam and Uma madam for chairing the session. And I thank all the members for participating and hope to see you in many numbers as usual as today, madam.
Yeah,
Thank
only
you.
Shobha, there are just two things
Yes, madam.
which I thought that Bella and others maybe could join in here on the because Sonia has given in input that she has tried to check tests for quantification of hepcidin levels, but no standardized assay available. Any inputs on this? So anybody wants to comment on that?
Yeah, there are levels are not been given and the discriminatory.
Even I have never found that. Yeah.
So, but there is a search is on that, and shortly probably we'll get the hepcidin levels.
Yeah, the studies are there are some studies being done, madam, on these now.
I mean, even if it is there, how much will it help us? I really doubt that it will really help us greatly. Maybe that is why funding is not happening for those studies, you know.
No, basically,
It's
Shobha, it started in 1990, though the hepcidin was identified, but the levels at which and the tests what they detect the levels are yet to be, streamlined on this.
And day to day, it will keep on changing, depending on the need and all. It's not like
No, but I
what
feel
you get. Yes,
it's really high time that
variation is there.
anemia is dealt with. Really high time because so much progress the country has done. It
But
is now
still we lack,
acknowledged.
madam. Madam, by
Alba?
2027, I think Bellat
Very
sir
sad.
will also come up with one more project and one more publication on this, sir. Looking forward for this.
No, why? Do we fail?
I think adolescent, madam,
Maybe it is the compliance.
school going children.
It is not only the compliance. There are so many factors involved in this. Even when
and
we
loss,
give
blood loss also.
I think there is one
loss, not only that,
comment
madam,
by
there are
Tripti Rani.
no, there is a hypothyroidism. There can be hypothyroidism prevents, this the erythropoiesis. There are many
Intervenes in the
factors.
intrinsic factors, sir. Intrinsic factor in hypothyroidism, sir.
Yeah, there are many.
There is
There is a
less
Castle's
absorption.
intrinsic factor, vitamin B12 deficiency.
B12
All
deficiency.
all these are impacts.
it is basic. It is basically multifactorial, madam.
Multifactorial, correct.
Yeah,
And increased incidence of
I
PCOD
feel
leading to
very, very strongly that Indian diet has a very major role to play. for
the consistency,
malabsorption of all these nutrients and minerals and
consistency
some
of the ongoing
micronutrients.
treatment. They usually don't continue till we reach the
Compliance is a
targets.
problem. Yes, compliance is a problem. But I am talking about why it should happen. Why should they be anemic to begin with? Even after socioeconomic status improvement, why there should be so much anemia? I feel Indian diet has something to do. The way we cook, the way we eat, there's some problem is there. Diet also has to yield some answers, I feel, in this. So I think very thought-provoking panel, Dr. Bellar, and that is why I am appreciating it so much. And I think Shobha has done full justice given the vote of thanks, and we must end it now. Yeah.
Thank you so much.
Thank you, everyone.
Thank you.
Thank you,
Thank you so
everyone.
much. Thank you.
Good night.
Thank you, everyone.
Good night.
Good night.
Good night. Good night. Good night.
Thank you.